there, welcome all. I'm Cecily Roach. I'm a peer support pharmacist and I have the absolute pleasure of acting as facilitator tonight for this week's webinar discussion on open disclosure, policy procedures and legislative requirements for pharmacists. So for those who've just joined, you'll see that the meeting is being recorded. Just press the OK on the top right-hand corner of the screen. You get rid of that bar. Your microphones have been muted, but the chat box is active throughout the evening. So please, if a question comes to mind, a comment or reflection, pop it into the chat box as you go, and we'll make sure and have time for questions and answers at the end. Have your videos on or off as you wish. Usually, if there's any question of connectivity issues, you're better to turn off your video. If you've difficulty with sound, of course, what can happen is sometimes if we're wearing headphones is we accidentally hit the on off or the mute button. If all else fails, try logging off and on again. If it's any consolation, I had to do exactly that about 20 minutes ago. Letting you know that we may use some information from the webinar, absolutely anonymized, of course. And what I would absolutely encourage you to do, and we'll remind you as the evening goes on, please do complete the post-webinar survey. And if something crosses your mind during the session saying, wasn't really sure what XYZ was saying there, and it prompts you to think of another topic for a future webinar, please obviously include that in the feedback as well. So our presenters for this evening, we have the great privilege and pleasure of having two presenters tonight, both from the HSE. We have Róisín Egenton, General Manager for Incident Management in Open Disclosure in the HSE. And we have Eleanor Southgate, who many of you probably remember as one of our speakers for a webinar last June. So this evening is building on last June's webinar, giving us updates, etc., as you'll have seen from the description on the enrolment and sign-up area on the IIOP. And Eleanor, of course, is National Open Disclosure Manager with the HSE. And now, in order to make the best use possible of the expertise we have, I'm going to hand over to Róisín and to Eleanor. Every good luck with that.
Thank you so much. Thanks, Cecily. As introduced, my name is Róisín Egenton. I'm a General Manager for Incident Management with responsibility for open disclosure in the HSE. I came into the role only 3 months ago now, and prior to this, I'm 20 years in the HSE, but the last 10 principally in quality improvement. And I've worked in incident management, primary care, and PCCC, as we used to call it back in the day, around across community and continuing care. So delighted to be here with you today. And I'm joined by my colleague, Ellie, who some of you would have met last year. Ellie, if you want to introduce yourself too.
Thanks so much. Absolutely delighted to be here. My name is Eleanor or Ellie Southgate. I've been with the Open Disclosure Program for 2 years now. My background is as a physiotherapist in trauma and orthopedic specialty. But I moved out of that and have been working in engagement with staff and with patients in a variety of settings in the UK National Health Service. Largely working in incident management as well. I'll hand back to Róisín, who's going to start the presentation.
That's great. Thanks, Ellie. So I'm just going to share our slides here today with you. And Ellie, you can let me know if this share is okay, please.
Yep, you're there once you've done the larger view.
Great. Okay, I'm just clicking on slideshow. So today we're just going to be taking you through, it's a bit of a refresh for those of you who were with us last June, bit of a refresh on the Patient Safety Act and the legislation, but we're also going to be telling you a little bit about the open disclosure policy and procedure, which will be coming out in the coming, dare I say, weeks now, next 2 to 3 weeks, it will be launched, as well as the procedure with that. And again, we're trying to put the angle on it for yourselves as relevant to you as pharmacists and as members of the IIOP. So we'll start off with definition of open disclosure. And this definition was in place for our 2019 policy, but it's been refined based on a lot of consultation and engagement when we were revising the policy for the 2025 version that's coming out in 2 weeks. So open disclosure is defined as an open, honest, compassionate, and timely approach to communicating with patients, or where appropriate, the relevant person or both of them. Following patient safety incidents and, as is new to the policy, notifiable incidents. And that was added in subsequent to the commencement of the Patient Safety Act on the 26th of September last year. It includes apologizing and expressing a regret for what happened. And again, that's another timely change that's made to the definition of open disclosure in the new policy. That apology has been put in. Prior to this, it was expressing regret, but the apology is very important to the definition of open disclosure and the process that's taken place. Secondly, is keeping the patient, or again, the relevant person, informed and providing reassurance in relation to ongoing care and treatment. And then, most importantly, really at the end of this, is not to just let the open disclosure be about that one communication, that one part of the process, but the learning and the steps being taken by the health and social care service provider to try and prevent a recurrence of a similar incident. The Open Disclosure Office is part of the wider QPS Incident Management Team, and open disclosure is an integral part of the incident management process. So we do have a QR code there. We'll be sharing the slides with you after this. And if you click on that QR code, it'll bring you to our open disclosure website, but I think we'll put it in the chat as well. It's www.hse.ie/open disclosure. So easy one to remember. As I mentioned, the Open Disclosure Office is part of the Quality and Patient Safety Incident Management Team, which is part of a wider national quality and patient safety function. And we work with individuals and teams to design and deliver the national policy, such as the Open Disclosure Policy, programs like our extensive training and education program, and resources, which we'll come into in a few minutes. And they're aimed at building individual skills, knowledge, and confidence in undertaking the open disclosure process. So our work, as we mentioned, is aligned to legislation, such as the Civil Liability Act and the Patient Safety Act, healthcare regulation, the National Open Disclosure Framework, which was published by the Department of Health in 2023, professional regulations and guidelines, national reports and recommendations, again, the Scally report from 2018 and other reports would feed into our work, and the Incident Management Framework, which as well is being updated this year. So the Incident Management Framework was last updated in 2020 and is currently undergoing quite a large piece of work with the Department of Health to have that revised and republished within the next, let's say, 4 months. So that's quite an accelerated piece of work. In terms of that national quality and patient safety function that I mentioned we're part of, these are the other components on it. I won't dwell on it, but it was just to give you an idea of what the national quality and safety function is, patient safety function is in the HSE. So I have in blue there our QPS Incident Management Team, of which our open disclosure function is part of that team. We also have QPS Education. The education team designs a lot of our education programs on HSE land, as well as some of the online ones that we deliver, the presentations. And they also inform us as to competency frameworks. They've developed a competency navigator recently, which is really, really interesting. And that's around your skills and capabilities for quality and patient safety on a broader basis. And they also publish our annual prospectus. The QPS Connect team is key for networking and providing information out to the service and really bringing back the learning as well. So some of you may have participated in the QPS Talk Time. That's a fortnightly webinar delivered by that team. They also have newsletters and journal articles, and they support our participation at conferences and events. As well as that, we have a podcast actually called the Walk and Talk Improvement Podcast. You can find that on any of your podcast providers. So I'd recommend those are nice 30 to 35-minute podcast episodes. If you're out walking the dog or in the car driving someplace, they're a nice resource to listen to and get a dose of quality and patient safety. Our National Centre for Clinical Audit was established a couple of years ago. And again, that is a major function that's operated from within our division. We have the National Independent Review Panel and the confidential recipient, both reporting into us under our National Clinical Lead, Dr. Orla Healy. Our QPS Improvement Team there at the top is responsible for delivering capacity and capability education programs around quality improvement. So again, taking the learning from incidents and from clinical audits and driving quality improvements using those small iterative tests of change and the science of improvement. And then finally, our QPS intelligence team. They're our data experts. And what they do is they take a lot of the information that's out there and they triangulate it to try to provide more information to the system and that intelligence around quality and patient safety. And at the moment, they're working with our QPS education team in helping to drive the new public health strategy for Ireland. So that's just a snippet of what our wider national and quality and patient safety team do. But coming back to open disclosure, we just have a very short video we'd like to share with you. And it's coming back to the importance of open disclosure. And I think the lived experience really, this is the reason that open disclosure has come to be and why it's so important internationally. And it's people like Bernie O'Reilly, who's a patient advocate and a member of Patients for Patient Safety Ireland, who we work very closely with. She is one of the driving forces behind open disclosure in Ireland. So we do have a video that she has said we're welcome to share with you today. There's no sound, just to mention, for the first minute of it, but hopefully the sound will kick in. So Ellie, you might give me a thumbs up if it works. Frozen there. Let me try it again. Oh no, it seems to be working.
My husband died 9 years ago from sepsis following a medical misadventure. Initially, I felt the staff in the hospital showed empathy towards me and my family, and I definitely felt that the staff in intensive care were excellent. Within a month of my husband's death, when I went to meet the consultant, I felt that he was evasive and that I wasn't getting the honesty that I felt initially I was going to get. By the time we got to my husband's inquest, I definitely felt we were on totally different sides, that we all arrived with legal representation, and I just felt that any chance of total honesty or open disclosure was just not part of the scenario. I didn't quite know.
I think we might have lost Róisín.
Okay, sorry about that, colleagues. I will start sharing from where we were there and carry on after the slide that we were on there. I'm afraid we'll have to lose Bernie's video and land on the slide that Róisín was going to speak to you there about. But we're just wanting to, as Róisín said in her introduction, pull together the connection between our work and your own, and that is to give some of the information that we have on medication incidents that we have gathered, and will be familiar to a great number of yourselves, but it's worth indicating the incidents that we see and we support staff with right across the HSC to deliver open disclosure after the medication incidents. I won't dwell on the data here, but you can read it both here and when you come back to review it and when we share the slides for this. Indeed, there's more information there, and what is a particularly striking data there is the syringe driver, syringe there at in the bottom right, that gives you the indication from our National Incident Management System, the NIMS system, on the categories of the most common medication incidents. And again, I'll leave you to digest this in your own time. But again, this slide is to indicate again those instances that we're talking to staff with on a daily basis about managing the open disclosure of. So now we're going to move on to the Patient Safety Act, or there it is in its full title, the Patient Safety Notifiable Incident Open Disclosure Act, which, as Róisín said, commenced in September. This is taken from the title page of the Act. And with every piece of legislation, we set out with a page that gives us an overview of what the Act is going to cover. So it has introduced a legal framework for mandatory open disclosure of certain incidents, and those incidents are called the notifiable incidents. And the Act outlines 13 where open disclosure must take place in line with the legislation. And those 13 are listed in the schedule at the back of the Act, and they all describe incidents. 12 of the 13 describe incidents in which, sadly, the person has passed away. And the 13th has an A and a B, and they refer to a neonate who may or may not be receiving therapeutic hypothermia. So these are very rare incidents. And the legislation, or the writers of the legislation, have chosen these 13 because they are very significant incidents that should be notified both to ourselves and to the regulator. And that's that next point there, that the notifiable part of that notifiable incident is a notification to the regulators. So depending on who regulates the service in which you work, you will inform that regulator. And you will be doing that via NIMS, as it says there, if you are working in HSE or an HSE funded service, or that is a Section 38. And if you're working in a private service or a Section 39, you'll use a portal, which is very similar to NIMS, styled on NIMS, but it sits on the regulator's website. Once you have completed the steps in line with the legislation related to the mandatory open disclosure and the notification to the regulator, the information shared at the time of open disclosure and any apology made is subject to certain legal protections. And you can refer to those in the legislation itself, but we won't fix on that tonight, but I'm happy to take questions on it if you have further questions. There are provisions and procedures in respect to clinical audit and outlined in the Act. There are certain enhanced powers, expanded powers for the monitoring private hospitals for HICWA, and not commencing at this time, but there is written into the legislation further powers for the Chief Inspector of Social Services for the review of specific incidents. And again, that's not commencing at this time. There's amendments to the Civil Liability Amendment Act, which, colleagues, you may know is the precursor to this Patient Safety Act. It's the first step towards putting open disclosure in a legal framework, and I'll talk about that in a little while. And then there are certain mandatory disclosures that are required when a patient requests a review of their cancer screening history. So here are the notifiable incidences exactly as you'd find them in the Act, as I said, in Schedule 1. And those of you who are have seen it before or are seeing it for the first time, indeed, you'll see the language starts to repeat itself as you go through each one in turn. And that's what we're focused on in the next few slides, is the repeating language that needs a little unpacking. So unintended and unanticipated deaths are used, again, as I say, to really refine that these incidences are incredibly rare. So they're deaths in the intended definition that is defined in the Act is a death in relation to or arising from an unintended event occurring or arising from the provision of the health service. Unanticipated death is not defined in the Act, but is understood to mean that where there was a death other than an anticipated or expected death, or a death where there was no expectation that the person was likely to die in the manner or time in which they did. Again, so as I say, we're refining it down, the scope of these incidents. And finally, there's this longer phrase which relates to the death not arising from the consequence or an illness of the underlying condition. And again, we're narrowing the scope as we go through these clauses of each notifiable incident. The Act speaks about a notifiable incident being recognized and identified when the health service provider is satisfied that it has occurred. And the HSC is interpreting this to mean that it is not a requirement to establish with absolute certainty in the legal sense or to determine a cause of death. Rather, it's a reasonable clinical assessment weighed with the information available at the time on the likelihood that a notifiable incident occurred. So we're just trying to help, again, unpack the language that's in the Act because, as I say, these are rare incidents, they're very serious incidents, and they need very careful handling. So you'll find this in our policy, as that Róisín referred to earlier, and you'll find it again in our notifiable incidents guideline that will be coming out again also in the next few weeks. So the next few slides are trying to support, again, with definitions and supporting understanding of these 13 notifiable incidents. So the following are the incidents that take place that are unanticipated and unanticipated patient death, which did not arise from or was caused by a consequence of an illness or underlying condition. And the first five rather, are related to surgery. So it's a death where surgery was performed on the wrong patient. And the next is surgery performed on the wrong site, a death after a wrong surgical procedure, and a death after an unintended retention of a foreign object after surgery. So again, you can see they're quite rare circumstances. And then we get to a wider scope one, which is a death after undergoing elective surgery, where the death is directly related to the surgical operation or anesthesia, including the recovery from the effects of the anesthesia in an otherwise well patient. And we're taking the description of otherwise well patient to be a score of 1 or 2 on the ASA score, which will mean something to certain colleagues, but if you're not somebody who works in a surgical specialty area, then it's not for you to need to know, but you'll know that, as I said, there's more information in the forthcoming notifiable incidents guideline. And then more relevant to yourselves is that there is a death in this next notifiable incident that is related to any medical treatment, and then due to a transfusion of an ABO incompatible blood or blood component. And then finally, of course, most important to yourselves is a death associated with a medication error or medication incident. Over the page, we have further notifiable incidents. The next 3 relate to maternity services and neonatology services. So we have an unanticipated death of a woman while pregnant or within 42 days of the pregnancy from any cause related to or aggravated by the management of the pregnancy. And very key here in the next 3 are those last few words that are that it has to be related to or aggravated by the management of the pregnancy. So the next one is a stillborn child, sadly, where the death was aggravated or by or related to the management of the pregnancy and not related to the underlying condition of the child. Similarly, a perinatal death, again, and the death is caused or related to the management of the pregnancy. And you'll just see there that there are some terms such as prescribed gestational age, prescribed birth weight, and those have been defined by regulation. Again, if you want further information on that, we're very happy to share that. But again, it'll be in our policy and in our notifiable incident guideline. The next one, 1.12, notifiable incident 1.12, is an unintended death where the cause is believed to be the suicide of a patient while being cared for in or at a place or premises in which a health service provider provides a health service. The last few words of that are very key here. So the person has to have sadly committed suicide on the service provider's property. They're very footprint, geographical footprint, if you will, and you can understand why that would be. And then the last one, as I say, that has an A and a B section is related to therapeutic hypothermia. So it's the baby who, in the clinical judgment of the health practitioner, requires or is referred for therapeutic hypothermia, or has been considered for but did not undergo therapeutic hypothermia because of the severity of the presenting condition and complications, comorbidities. So those are the notifiable incidents. And then finally, I'll just draw your attention to the note in the bottom left there in red, that the minister has reserved the right to make further regulations, which is additions to this list. So currently we have 13, and as I said, 12 of those 13 relate to the death of a patient. And the 13th relates to a neonate. So in the next few slides where we talk about open disclosure, we talk about open disclosure to the patient, their relevant person, or both, and that's the wording in the legislation. But that was future-proofing the legislation for the potential that there may in the future be notifiable incidents where the patient hasn't passed away or is not a neonate, and then the open disclosure would be made directly to the patient. That is the regulation I was describing that refers to prescribed birth weight and prescribed gestational age. And I won't linger on that. Suffice to know that it's set out, and those working in maternity services, neonatology services would be quite familiar with these definitions. And again, here's a slide that just indicates that if you're an individual working in the community services where previously you would report to the Mental Health Commission, you are now required to report to HICWA with all of your notifications that you previously made to Mental Health Commission. That includes notifiable incidents. Again, I'll unpack that further if there's a question from colleagues here about that, but I won't dwell on it right now. So I referred to the amendments that were brought in by the Patient Safety Act to the Civil Liability Act, and that is that the Patient Safety Act makes provision that if you choose to pursue open disclosure exactly in line with the Patient Safety Act, but instead of it being a notifiable instance that you're making open disclosure of, it is just any patient safety incident, that you will have the same protections for the information that you share in your open disclosure and any apology that you give in your open disclosure as are described in the Patient Safety Act for notifiable incidents. As it says there in the second bullet point, it's a similarly prescriptive process, the key difference being that when you write to the patient or relevant person following the open disclosure meeting, which must be pursued within 5 days of that open disclosure meeting, that letter must include that the open disclosure meeting, was held in compliance with Part 4 of the Civil Liability Amendment Act. And just to further make it clear that whilst you're pursuing it for a patient safety incident, not a notifiable incident, it is voluntary. It is not mandatory that you make your open disclosure in line with the Act. You're just electing to seek those protections for your information and apology offered. So this is only for patient safety incidents that have occurred since commencement, since, as it says there in bold, the 26th of September. And we're just drawing out here the key points of what I've just been speaking to that have changed since the introduction of the Patient Safety Act. And just as it says here, that'll be drawn out in our forthcoming open disclosure policy. But as it says in bold, if you have identified a notifiable incident, you must inform the relevant regulator within 7 days of when the health service provider is satisfied that a notifiable incident has occurred. And that must be via NIMS if it's HSE, and via the portal that I described being on the regulator's website if it's Section 39 or a private sector facility. It is legally required that you appoint a designated person and you record that in writing. Following the open disclosure meeting, you write to the relevant person within 5 days of the meeting happening. There are record-keeping requirements through all stages of the process that must be followed, and offences and penalties apply for non-compliance. Further information is available on the Act. There's an HSE land module that we've developed on the Act, and indeed on the role of the designated person that I just touched on there. There's a designated web page on the Patient Safety Act giving you an overview of the Act that I've done very briefly now. There's resources to support the implementation of the Act in your service. We have produced a number of webinars focusing on the detail of the Patient Safety Act that can be accessed by the QR code on the far right. I can't quite see just at the minute if Róisín is available, but if she is, she can interrupt me now, but otherwise I'll keep going.
Yeah, I'm here. Can you hear me,
Oh,
Ellie?
you are. Okay, yes, I can. I'll keep sharing. You give me the nod and I'll move the page. Okay.
Thanks. Great. Thanks, Ellie. And thanks so much. Apologies. My laptop decided to go south on me during Bernie's story. But just to let you know, we do have other videos that we can share with you that Bernie has offered her story in other circumstances and the importance of open disclosure. So I won't go back on that. I'll keep going forward. So as Ellie outlined about the Patient Safety Act, and just to mention, we do have a lot on our slides in terms of content, but the reason for that is because we do find that after webinars like this, people do like to go back and unpick pieces from it from the slides and digest it a bit. So we would rather provide a little more that you can go back and read on at your leisure, and we won't go through every word of it here on the webinar now. So in terms of the open disclosure process, what we have outlined here is around the open disclosure policy and procedure that we will be, again, publishing within the next 2 weeks. So the open disclosure process applies to, as Ellie said, notifiable incidents. So they're the ones outlined in the Patient Safety Act 2023, and also Category 1 and Category 2 patient safety incidents. So those are the ones where there has been moderate harm, severe harm, or permanent disability or death. And in the open disclosure policy and procedure, we have tried to line up the Patient Safety Act with our previous policy and procedures to make it as streamlined as possible so that the policy could be people's one-stop, the first place you'd go to be advised as to the steps to take around open disclosure. Because again, the patient safety incidents, the notifiable incidents, for people that are new to this, we really outline it in detail and we try to make it as simple to follow as possible. Again, it's called a process because it's more than just that one meeting or conversation. And I mentioned that earlier in the webinar. It's an entire process, and we do like to see it closed out through the sharing of review findings and following the people and the patients and their relevant persons beyond just that initial meeting and clarification. In terms of when open disclosure should take place, we do say that it should commence as soon as practicable. So initiate it within 24 to 48 hours of becoming aware of an incident. And we do realize that in the course of health and social care that you may not know that something has been an incident until days or even weeks after it's happened. So once you become aware of the incident, to initiate it within 24 to 48 hours. The duration of the process will depend on the incident that occurred, the number of patients involved, the progress of the incident review again, and really the important thing is addressing the immediate and ongoing needs of the patient and relevant person, that their needs won't just stop at the end of the open disclosure process. So it's being cognizant of that and how we can support them. So the 5 key steps that we have here, and I'll be sharing with you over the next few slides, are again, from the preparation, the meeting itself, the documentation and written follow-up, some of which is prescribed by, again, legislation and Patient Safety Act, the ongoing communication, and then finally, the sharing of review findings. Next slide, please, Ellie. In terms of the Category 3 incidents, the minor or no harm ones, we do in the policy and procedure outline what we refer to as a low level of response to those minor harm incidents. So the low level response doesn't necessarily need to follow the open disclosure process that we go the entire process, but it is important that we maintain that openness, honesty, and transparency. So it could be a conversation with the patient or the relevant person to acknowledge what happened, to listen and hear their story and their understanding of what has happened, to explain what's happened, to respond to any questions openly, to provide that meaningful apology, and to provide reassurance in relation to ongoing care. And again, that conversation must be documented in the healthcare record. And two of the key questions you might ask yourself, if it has been a no harm event or a near miss, you might ask yourself, is there a chance this might happen again? Is it something that you need to make the patient or relevant person aware of? Because it might be something perhaps in their control or in a staff member's control. It could be something that might happen again. So we want to increase their awareness that it was a no harm or a near miss event. Or could there be learning from it? Could there be learning that benefits the system, benefits the ward, benefits your service? So if there's learning, or if it could prevent future harm, those are kind of the litmus tests for when we say whether you should, disclose in those circumstances. And that low level of response is usually recommended for that. Next slide, please, Ellie. Thank you. So going back to the open disclosure process, so this is again for the notifiable incidents and the Category 1 and Category 2 incidents. In preparing them, who makes the open disclosure? So it is the patient's principal healthcare practitioner who leads that process and discloses the incident for the Category 1 incidents and the notifiable incidents. For Category 2 incidents and minor harm incidents, it may be another suitable staff member. Or somebody else who is of appropriate responsibility and who has that rapport with the patient and who is overseeing their care. Who is the open disclosure made to? We've already mentioned, and Ellie explained that in terms of notifiable incidents, at the present, that will principally be to a relevant person. But again, it is safeguarding the future if the minister does decide to add more notifiable incident to the lists. It may one day indeed be to the patient or the patient and the relevant person. And again, for patient safety incidents, it could be to the patient or again, relevant person or patient and relevant person, depending on the circumstances. The timing of open disclosure, as we've already mentioned, is as soon as practicable and deemed appropriate by the health service provider. But it's not necessarily to know all of the information. So what we used to see in the past, going back several years ago, that there was a culture of services wishing to be open and transparent, but being nervous about starting that open disclosure process before they knew everything about the incident that had occurred. But what we recommend is have that conversation with the patient or the relevant person. The most important thing is to initiate that conversation, to recognize the incident, to make that apology and to say, we will continue to be in touch with you to let you know as we learn more. So not to delay the open disclosure because you're waiting for more information. Ellie, next slide, please. Thank you. So preparing for the actual open disclosure, we do have a number of resources we can signpost you to help with this. But we say, look at the circumstances of the patient and the nature of the incident. Talk to any person as appropriate who is involved in the incident, involved in their care, or may have something they'd like to say on it. Consider who the open disclosure will be made to. Again, is it the patient? Is it the relevant person? What are their circumstances? What's their current state of mind? How can you phrase it? How can you frame it to be sensitive and yet open, transparent, and empathetic? Discuss with the team the apology to be provided, how you'll word that, and exactly what the service is apologizing for. And consider how the information can be relayed so that it's clear and understandable. And again, we do give advice in our own open disclosure training and webinars on different techniques for communicating, and particularly for communicating challenging or bad news, and different techniques that can be used to make that easier for both the people that are delivering the message, as well as to make it easy to understand for the people that are receiving it. So we would use, for example, something called chunk and check, where you provide a certain amount of information, pause, and then make sure the person listening to you has heard it and understands before you move on. We also say to appoint the designated person, and that's not just us saying it. The Patient Safety Act does have in it that the appointment of the designated person is required for notifiable incidents, and by our policy, it is also for the Category 1 and Category 2 incidents. And that designated person is a very key role. They're the linchpin between the person that is being disclosed to, either the patient, the relevant person, or both, and the health service provider. So that designated person liaises with the patient. The designation must be made in writing and kept on the record. And that's the person that assists them with the open disclosure process, with planning the meeting, with making sure that documentation goes out with them, to making a phone call to check on them to see, did they receive their letter? and if there's any clarifications that that person or relevant person has in relation to open disclosure, to go back and contact the service. So they're that go-between, that point of contact, and they really are the main point of contact for the patient. Next slide, please, Ellie. Right. So the open disclosure meeting is normally held in person with the patient or relevant person. However, they can request orally that to have it other than in person. So it can be telephone, it can be virtual, over Teams or Zoom. However, any request for it not to be in person should be kept recorded in writing and kept on record. Again, I've mentioned the chunk and check in the ways to provide the information in small intervals and to provide factual responses to any questions or clarifications sought. And again, our open disclosure policy gives points for discussion and a checklist for how to prepare for the meeting, who to have in the room, how to prepare for the communication. We also have a range of templates and resources and other short training videos and material that can be used to support that. Next slide, please, Ellie. So again, as prescribed in the Patient Safety Act, but also noted in our policy, that the open disclosure meeting must be followed up in writing with the patient relevant person as part of this open disclosure process. So it's imperative for them as good communication. And in the past, that written communication may have been in the form of a template, but we do recommend in the current policy that it's a more personalized letter. And we feel that's a much more empathetic response to people, that written communication and follow-up, again, does reinforce the apology, and that it's a compassionate summary letter summarizing the points that were discussed at the meeting. As Ellie mentioned, Patient Safety Act does prescribe certain time periods there. So if managing the open disclosure under legislation, it has to be sent within 5 calendar days. And we do stress that it does say calendar days rather than working days or business days. And we do appreciate that can be a challenge for people who might be on shifts or people who might be, for example, leaving the country or coming into the country, what have you. But that 5 calendar days must be strictly adhered to. And again, we do have a link there that will be shared with you with sample templates to support that documentation. Next slide, please. So the ongoing communication piece is really key. So after that open disclosure meeting, after the written communication to their patient or a relevant person, the communication will continue following on the open disclosure meeting. And principally, it'll be through that designated person. But additional open disclosure meetings may be required. And that could be the case where, again, the initial open disclosure was saying, look, we don't know everything about this yet, but we'll come back to you with more information. So it could be follow-up meetings where the health service provider gives more information. But it could also be requests for clarification. So following an open disclosure meeting, the patient or relevant person might go away, they might receive their documentation following the meeting and think, gosh, at the time, I never asked this question, or it didn't come to mind, it's only coming to me now. And they may request further clarification. And again, it's very important to stress that any requests for clarification must be followed up on. And again, if they're being managed under the legislation, they have to be followed up in writing within 5 calendar days of providing the clarification. So again, it's very prescriptive as to the timeframes for this information to be provided back. So again, we can't say it enough. Good record keeping is really important in relation to open disclosure. For managing clarification requests, we do have, as we mentioned, a documentation template with examples to support services. We have a QR code there. We do have templates and we do have information that can be triangulated across from NIMS for the incident reference numbers. So this will all support you in documenting the open disclosure and the clarification process. Next slide, please, Ellie. So the last step that we have in the open disclosure process is around sharing the review findings. So following that honest and complete open disclosure, it's sharing the review with the patient or the relevant person. But it's really important to note that second bullet point there. It may be closing the open disclosure process, but it may not be closure for the person that's been impacted. And for the remainder of the video, unfortunately, Bernie's video that froze on me there, she was saying that, you know, even though it's 20 years now since her husband passed, she's come to terms with being a widow. She's come to terms with his death, but she has never come to terms with how it happened. She's never been able to come to terms with the incident. That has stayed with her. So often the closure of the open disclosure process is not a closure for the person that's been impacted, or indeed the healthcare staff that have been impacted. So we need to be really aware of the supports that are required on a longer term basis for a person impacted, or indeed for the health and social care staff that have been impacted. So that designated person can be really helpful in understanding what supports might be required for a patient or the relevant person, and signposting them to supports where they can. And we do encourage feedback from patients or relevant persons on the open disclosure process. So that designated person might contact them after that sharing of review findings to say, how did you find the open disclosure process? What made it work well for you? What could we have improved on? And that learning is really critical for us to share the learning, not only in the service, but to share it across the wider health and social care service in Ireland. So we can make open disclosure even better as we move forward. Just another consideration here, and this has come up with a number of services we have mentioned. Open disclosure is generally a shared professional responsibility, and a collective approach should be taken to accountability. And that is particularly where there may be a number of services or service providers who are involved in a patient safety incident to some degree. So, for example, in the referring a baby for therapeutic hypothermia, the baby may be born at one hospital, which doesn't have the facilities to provide therapeutic hypothermia. That baby will then be transferred to another facility. That notifiable incident of the therapeutic hypothermia needs to be initiated by the source of the referring service, so the hospital in which the baby was born. So that third bullet point there we're saying is that the team or service whose care the patient was under at the time of the incident, and for that one with therapeutic hypothermia, it's the referral. And they're the ones that will lead on the open disclosure. So they inform the patient and initiate the open disclosure process. But they will also inform the other service. So it's really important to have that communication across services. And for those of you who are using the National Incident Management System or the portal to report them, if you do use the notes section on that for recording incidents, it's really important to use that to say other services that were involved, because that helps the Quality and Patient Safety Service from a national level to understand and to understand the story and the person's travel through an incident, so that we can kind of connect the dots from the incident management perspective. So that last point there is again reiterating that the open disclosure process and open disclosure meeting lies with the team or service whose care the patient was under at the time the incident occurred. So I'm going to hand you back now. I'm conscious of time. I know we have to have some time for Q&A, but we only have, I think, 3 or 4 slides left, and then we can open the floor for questions. So I'll hand you back to Ellie, who will take us through the open disclosure framework.
Thanks so much. So our colleagues, you will be aware if you joined last year to listen to our webinar at that stage that we spoke about the National Open Disclosure Framework, which was launched by the Department of Health in 2023. And it was with the ambition of embedding a culture of open disclosure across health and social care services, both in the HSE funded and in the private sphere of health and social care provision. It also applies, as it says there, to regulators and education institutions. So it really is quite an expansive ambition. And you have to kind of admire that ambition for a culture right across all of our health and social care services, for exactly the reason that Róisín was unpacking there, in relation to services that, they don't stand alone and they refer to each other and speak to each other. And just the last point there, that culture will be driven by, as the framework sets out, clinical and managerial open disclosure champions. It also requires that leadership are engaging and pursuing the ambition of this improved culture for open disclosure in their services, engaging with feedback, training and development in their services to ensure that they are aligned with the framework and the ambitions it has for a culture of open disclosure. And to put assurances on that ambition, it requires that annual report to be shared with the Minister of Health annually on the following reporting requirements. This is the first year. This April will be the first year where that report is required to the health minister. This year, we, as the sort of test pilot year for that, there in the HSE, there is not the expectation to report on all of these, but we are encouraging services, and you may be aware that we have already written to REOs for there to cascade through their services, that they need to be feeding back on some of these points, and that is to be feeding back on the development and implementation of open disclosure policy within their services, the training for open disclosure in their services for clinical, non-clinical and agency staff, and discussing the appointment and of the clinical and managerial open disclosure champions. In the future, there will be a requirement to report on the number of open disclosure events initiated and closed. So it is a substantial ask. And if you're engaged on this process and you want to become a champion, it really will be for yourself and your service to get involved and lead this culture of change. I'm aware again that time is short and we want to hear your questions, because that's the most important part, really, of coming to engage with yourselves, so we can improve all of our training that we offer. But here is what we currently offer, and I just draw your attention most importantly to Module 1. Which is mandatory for all staff in the HSE, both clinical and non-clinical, and that must be refreshed every 3 years. So if you're in your service and you're aware that colleagues might not have the full foundational level of information about open disclosure, then you be doing your great service to yourself and your service, and the culture for open disclosure in your service, to steer them towards that Module 1 available on HSE land. We say, or rather it is said by HSE HR, that anybody engaging in the delivery of open disclosure must complete Module 2 and Module 3. Module 2 being HSE e-learning, Module 3 being a face-to-face skills workshop. And we've referred to these already, offered you QR codes to these first two, which are on HSE land, and they are an overview of the Patient Safety Act and the role of the designated person. And finally, we have a train the trainer program. So if your service really wants to roll out open disclosure right across its teams and services and departments, then we can come and deliver training, so that there's a trainer in your own service that delivers skills workshop on open disclosure. And that's really for booking through our own office. I will zoom through these because we're very short on time at this stage. I'll stop sharing, and I'll ask whomever is moderating to ask for questions. Thank you.
Thank you both very much. Much appreciated. I know that there are at least 3 different questions in the chat box, but perhaps to ask you a general question that we know comes up regularly, and you touched on it, but if one of you would like to expand on it, this concept of there being reference to both apology and regret. And could you speak to that a little more? A common question is, why both? Whether that means you distinguish between them or whatever. So I see Eleanor on screen there. Is that your area? And maybe
I might
Róisín,
hand to
take a look
Róisín
at
on
the
this,
chat.
because she's
Perfect, yeah. And have a look at the, I think some of the
policy.
questions could be banked.
Yeah,
Okay.
no
Yeah.
problem. That's perfect. That's a really good question, Cecily. And that was one that has been discussed quite a lot. I think really the reason that the apology was put in there is that from talking to patients, service users, relevant persons, anybody that's been involved in an incident, they often want the apology. The apology is so important to them. And we've seen that in very high profile cases, as well as the ones you don't hear about, is that the apology it's what people are looking for. And not only that, but the apology we find is central to that sense of openness and transparency. There tends to be a cultural fear of saying, I'm sorry. And that has people often, and the literature shows this, people often feel that saying, I'm sorry is somehow saying, I am liable, I have done something wrong. But expressing that apology, I think, is at the heart of that empathetic communication that we strive for in open disclosure across the service, and that culture change that we want to drive in. So that apology for us is really central. It's at the heart of that empathetic, honest, transparent communication, for the reasons I've stated. So yes, we made a point of including apology in the updated policy.
Yeah. And a sense that just expressing regret somehow sidestepped that piece of being sorry about. Okay.
Yeah, and for a lot of people, you've probably heard the differences between sympathy, empathy, compassion. Expressing regret is a very sympathetic response, whereas I am sorry, and that apology carries an empathy with it that I think just transcends that communication.
Okay, so a very important one for pharmacists. We know we need to be empathetic in order to understand the other's perspective, but you're giving us very clear direction there. We have a couple of questions. And I think some of them are functional. I know you've pointed us to HSE land and the quality, and it's great to have access to those. And to emphasize to people that my understanding is you update your resources on your website on a regular basis, so we can be confident that as the new policy rolls out, any teething problems will be reflected on what's on HSE land. But there's a couple of specific questions here. How do we apply incidents, or is it how do we upload incidents to HSE on a daily basis? I didn't necessarily hear a daily basis from you. And they follow that up with, is it something voluntary? I think you're making quite clear it's something that must be done by the healthcare practitioner who's the lead in the case. But the wording is, how do we apply incidents to HSE on a daily basis? Is it something voluntary?
I'll take that if I may. So if we're talking about an HSE or a Section 38 service, then they should be using the NIMS National Incident Management Service system for all incidents. And if they're not, or if they're unaware of how to access that, then they do need to get in touch with their QPS staff, or indeed their line manager or service area manager, because there does need to be that ability to log all variety of incidents, not just patient safety incidents. Of course, we care very much about our staff incidents as well, and they go on NIMS equally. I would say that a lot of services, when we came to the rollout of the new NIMS module, so with this, forgive me for the slight technical language, but when we were developing this new tab or button or form on NIMS, the electronic process, we became more aware of services that are still using paper input. So I might be working on a ward where access to computers is limited, and so that my service might provide paper forms for the submission of incident reporting information. And that's absolutely fine. That is a robust system. It's obviously something that will potentially be swept away in the future, but those paper forms are still very important for incident reporting. I hope that answers the question. I see
Yes.
also that another colleague in the chat has said, can pharmacists be added to the category of persons who can report on NIMS? And I think that exactly as you say,
Yeah.
it's a bit ridiculous that they're not. I agree wholeheartedly in that. Again, as a conversation for your QPS staff, I'm sure they would agree that it's important that you get on NIMS. The only thing we would say with NIMS, like any reporting system, any information management system, indeed, that the necessary training is very important so that we have the right level of information, the information is standardized, and Róisín is indicating that triangulation learning, etc., can take place. So a conversation to be had in your service.
Yeah, okay, and that's very helpful because NIMS was an acronym in an earlier question, and just to highlight to people, that's a particular system that mightn't apply to everybody on the call. I think thank you. You've managed to answer both there. I am conscious we're at 9 o'clock, a very long. I think you put in a very comprehensive answer, Róisín, to the question re mental health. I'd suggest that perhaps that can be available to people afterwards, whomsoever asked the question, I think is still on the call. So copy and paste that for yourself quite specifically. And I do think we have IIOP on the file there. There are a couple of slides I want to very quickly reinforce. I have popped in the link to the feedback a couple of times in the chat. It really is important. We're peer support pharmacists for a reason, to encourage that we get feedback on what's being delivered and what it has prompted in your mind that might be needed in the future. So very much encouraged to fill it out now. And of course, the whole background CPD for pharmacists is this reflective, self-directed approach. Start a cycle. If you haven't started a cycle, pop in a couple of quick reflections from tonight. You know that tomorrow the video recording, the slides, and whatever resources Róisín and Ellie really want us to have access to will be available on the website. So you can always finish it at a later stage, but pop in your immediate aha moments, reflections now into a cycle. And finally, to say that the next In Conversation With session webinar is Wednesday, 26th of March, same time, 8 p.m. And this one will be courtesy of Elizabeth Dorn, consultant neurologist at St. James's, on the PREVENT programme. And of course, we're thinking very much valproate there. And of course, invitations will be by email and all the usual social media channels. Away you go, active, spread the news of the wonderful session we've had tonight and the fact that it's available to us as a resource on an ongoing basis. Thank you, Róisín. Thank you, Eleanor. Much appreciated, and good night and enjoy your evening.